Welcome everybody to the first session that will be on documentation of sexual violence. This is the first session as part of our sexual and gender-based violence series, and we're super excited to have Dr. Kim Griswold here from University of Buffalo, one of my beloved mentors, and also one of the main directors of the Human Rights Initiative at Buffalo, which is our PHR clinic at UB. So Dr. Griswold, do you want to maybe introduce yourself and the topic, and we can get going here?
Of course. Thank you so much, Victoria. And it's a real pleasure for me to be here to talk about not only the documentation and the occurrence of sexual and gender-based violence, but to talk a little bit about the PHR student-run clinics and the whole asylum network that PHR runs. And you'll see as we go forward some of the work that's been done here in Buffalo, but is being replicated across our country in terms of people seeking asylum. So tonight we're going to talk about a little bit of the epidemiology of sexual and gender-based violence, and then the documentation of it and what we've done here to help our asylum-seeking clients. A warning before we begin, this presentation does include the slides and 2 videos with some explicit discussion of sexual violence, including language that can be upsetting. Please feel free to leave this presentation at any point and reach out either to me or to one of your peers or colleagues after this talk. So the Human Rights Initiative, UB, was founded in 2014, and it actually occurred because at the same time, the Center for Survivors of Torture was implemented at Jewish Family Service. And this was originally through a grant through the New York State Health Foundation, and now the Office of Refugee Resettlement funds the Center for Survivors. We, of course, as a student-run clinic, working with local clinicians, are all pro bono. We take no money for our work, and we receive nothing if we testify in court. But it was founded really because Buffalo is a hub, as many of you know, for refugees. There are 4 resettlement agencies, and for asylum seekers because of primarily Vive la Casa, which is the largest residential center in the United States for asylum seekers. Years ago, it was for people streaming into Canada, seeking freedom and going to Canada. But because that border is now closed, which happened after 9/11 actually, now our asylum seekers live there sometimes for quite a while before they find jobs or find their own places to live as they get settled and gain asylum. So the main purpose of our work is to provide these forensic examinations, either gynecological, which we'll be talking mostly about this evening, physical, for physical scars, or psychiatric, so that these testimonies and affidavits that the students scribe for and that we complete are used in immigration court in support of the case, if indeed there is evidence that is found consistent with what the asylum seeker has told us. If an individual does have a forensic exam, it significantly increases the likelihood that they will be granted some form of protection. Asylum is not the only form of protection that a seeker may have. There are other sort of lesser forms, but are still protective. And this was shown in a study, a seminal study done in 2008 by Lustig, and replicated just last year through work through PHR and other researchers, 2021. Showing that the people who had forensic exams, any one of these 3 kinds, were much more likely to have protection. And most of them, in the most recent study, were granted asylum. To date, our own clinic has served 180 clients, and we've done the gamut of all 3 of these kinds of examinations. And on the right, you can see in, I think this is the kind of map that you all do so well, that the bigger the word, the more people is shown. Victoria can correct me later if that's incorrect, but you can see that we've seen a lot of people from all over the world, the African continent as well as South America.
And no, that was accurate, Dr. Griswold.
Oh, good. I'm never quite sure. One of the things that has made me so passionate about this work is learning about the people who do it on the front line. And I had the immense honor of hearing Dr. Dennis Mukwege speak in 2014. PHR invited him to be the key speaker at their conference. They have an annual conference. He is an obstetrician gynecologist, Congolese, founder and medical director of the Panzi Hospital in Bukavu, DRC. He and Nadia Murad, who is from Iraq, Yazidi people, and they were granted the Nobel Peace Prize in 2018 because of their work against sexual violence and trying to heal the wounds that occur and also prevention. This is one of the videos that may be a little hard to watch at times, so please protect yourselves and turn it off if it becomes upsetting in any way.
She was a young woman, around 20 years old. 20 years. 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 This young woman was taken by soldiers, and 7 of them raped her in succession.
Et après, le dernier, après l'avoir violée, a pris son arme, il a mis son arme au niveau de son appareil génital et il a tiré. On l'a amené à Panzi, où je pouvais constater qu'elle avait tout l'appareil génital externe était en petits lambeaux. Et là, j'avais vu pour la première fois une barbarie que je ne savais pas m'expliquer.
There was more to come. Dr. Mukwege would see case after case, from very young children to elderly grandmothers, tortured with machetes, blades, sticks. Rape in the Congo had become a favored weapon of war.
J'avais inauguré vraiment un petit hôpital pour pouvoir venir en aide toujours aux femmes enceintes. Et d'un seul coup, je me trouve aujourd'hui à me battre contre la violence qui est faite aux femmes, une violence sans nom, une violence qui est tout à fait délibérée.
Dr. Mukwege and Panzi Hospital have treated tens of thousands of patients, healing the physical, psychological, and social trauma that results from sexual violence. Alongside Physicians for Human Rights, he educates medical, judicial, and community workers so that survivors can pursue justice. By speaking out against these atrocities, Dr. Mukwege himself became a target of violence. Armed gunmen attacked Dr. Mukwege's home, holding his family at gunpoint, and killing his friend and security guard, Joseph Bizimana. The doctor narrowly escaped, and PHR provided a safe haven in the United States, where he and his family could recover.
Nous sommes des témoins, et il y a deux choix. Nous pouvons décider de nous taire, et à ce moment-là, nous sommes complices de ceux qui commettent ces actes.
Mesdames et messieurs,
La deuxième possibilité,
j'aurais voulu commencer.
c'est de parler à la place de ces femmes et dire ce que nous voyons, témoigner de ce que nous voyons, dire ce qu'elles nous disent et demander à ce que ça cesse.
Despite the risks to his safety, Dr. Mukwege and his family decide they cannot stay away. In his return to Bukavu, thousands welcome him, lining the street for miles, surrounding and protecting him for a safe return to Panzi. Dr. Mukwege's vision and courage have helped launch a global movement against rape in conflict zones.
De ce qui s'est passé, il y a combien de temps?
He is the embodiment of a physician for human rights. He hears the women and girls of Congo. He helps heal their bodies and minds by speaking their truth and calling for change. He conquers violence with justice. We stand with Dr. Mukwege and honor his work.
So a little bit about the epidemiology, actually, globally, about sexual and gender-based violence. This is from the World Bank. There are many global institutions looking at this kind of violence around the world. 35% of women worldwide have experienced either physical and or sexual intimate partner or non-partner sexual violence. 38% of women globally are murdered by intimate partner violence. 7% of women globally have been sexually assaulted by someone other than a experienced female genital cutting. This is probably an underestimation because that is such a taboo subject and probably many women will not disclose. Anyone can be a survivor of sexual and gender-based violence. Certainly they who are gender diverse, women, men, girls, boys of any age and background can be affected. This is from UNHCR, United Nations High Commissioner for Refugees. And when they're looking, this is from an emergency document that they put out. And when they're looking to sort of seek to try to solve these issues and work with communities, it's very important to involve the entire community. Back in the day, it was, you would just work with women and children, but it's very important to involve men and boys in these discussions and educations around the world. There is an increase for sexual and gender-based violence, which is why we see so many asylum seekers, because when countries are in conflict and violence and in emergency situations, there's a complete breakdown, not only of family, but of all of the institutions and infrastructure that support families, and people are forcibly displaced within a country. And people who are targeted are likely to be people with disabilities, people from the LGBTQI communities, adolescents, elderly, and female heads of households. And we actually see that quite a bit among our asylum-seeking clients. Definitions are very important for our work with PHR and with immigration court. We have to use sort of evidence-based guidelines when we do the work. And in a little while, I'll talk to you a little bit more about the language we use in the affidavits. Rape, we heard the other day in another session we were in, that is sort of a legal term, and there's some confusion about that. I do use the word rape in some of my affidavits, but sexual assault or sexual violence is also a little bit harder hitting. And if I want to use a word that expresses the outrage that I have or that the woman has expressed to me, I might use that term. But in any case, in one study, it was shown that rape or sexual assault of some sort was as high as 90% among refugees and people who are fleeing violence. Okay. Female genital cutting is defined as all procedures that involve partial or total removal of the external female genitalia or other injury to the female genital organs. And we have seen other injuries, purposeful cutting through. One woman we saw had something that was trying to be cut into her from someone who had perpetrated violence. Forced sex work and human trafficking, we also have seen often with people fleeing through different countries, with, helped by agents, they're called, but they can also exact a price. And if you don't have money, sometimes the price is sexual violence. Forced marriage and cohabitation, and denial of the right to contraception, abortion or termination, and measures to protect against STIs. A few slides more now about female genital initiation. Perpetrators are often family members. It's often viewed as this rite of passage for young girls, although sometimes infants are cut. So that is done probably for a different reason than for the initiation. Perpetrators are often the female relatives, most often the mom, grandmom, aunties, or other women in the village. Nurse midwives often participate. And mothers may not understand the dangers of FGC. And if she does, she may not be able to help the daughter escape because it's such a strong practice in whatever community this is being done. And as we said before, it's meant to be very secretive. And often people will not even divulge to sisters. We saw one client who had been initiated, and she didn't know if her sisters had been because no one would speak of it in the family. Driving factors of FGC are gender inequality and patriarchal norms in many societies. Traditional leaders may demand that the sons marry someone who is cut. So most of what I have seen of this, and I've been doing this for quite a while, and it was the people that we used to see back in the late 80s, early 90s, they were mostly from Somalia. And their belief of female genital cutting was rooted in that cutting enhances fertility and sexual pleasure for men, that it suppressed the female sexuality so that she would be much less likely to practice infidelity, and that it led to better hygiene. And poverty also plays a huge role. Families who are unable to pay for basic food or costs of their own home see this child marriage or marrying off the daughter ensures her security and also the family's income. There is no medical benefit to female genital mutilation. It is mostly carried out between infancy and age 15, although we have seen women in their 20s and 30s who have been cut for reasons, many reasons. One woman I saw, whom I will never forget, chose to be in love with someone outside her religion, and her father purposefully, he himself held her down, and she was cut so that she would stay within the family. It was an experience that was very upsetting for me and for the students that were in the room, and of course for the woman herself. I'm happy to say she did get asylum. Regions that practice FGC concentrated in the African continent, but also prevalent in other countries, Iraq and Yemen, and it's found actually around the world. And this CDC data in 2012, but as I mentioned before, UNHCR found that over 200 million women had been cut. Now I'm going to go over the types of FGC and what we actually document for the asylum work that we do in the affidavits. This is from the WHO definition, and we use that because, again, it's it's evidence-based, and in court we want to use everything that the court doesn't have to question. It's not something that we came up with. This is something defined through WHO. Type 1 is partial or total removal of the clitoris and or the prepuce or hood. And if you want to really distinguish it, and sometimes we do, there's a type 1A, which is removal of the clitoral hood or prepuce only, and type 2, the clitoris and the hood. What you see on the right, that template, is what we use in the actual affidavit. We do not take pictures of the woman. We examine, describe, and then use this format for the affidavit in court. Type 2 is partial or total removal of the clitoris and the labial minora without the excision of the majora. And again, this can be brought down to other types, the labia minora only, partial or total removal of the clitoris and the labia minora, or the labia minora and majora. Type 3 is the most extreme. Infibulation. We do not see this per se when the woman presents to us. We did see one woman who had this done, but it had been opened up. When I was seeing Somali women in the early 90s, most of them had infibulation done, and at that time, Children's Hospital and gynecologists were undoing that surgery so that she was opened up. The problem with this is it's not only extreme and horrific. Once it is sewn together, once things are cut and it's sewn together, there's only one exit for menstrual period and urine. And you can imagine what happens, and we'll see that in a few slides. And this is then type 3A or 3B, removal and apposition of the minora and majora, either or. So this is the most extreme. 4 is classified by WHO as any other harmful procedure for non-medical purposes, piercing, incising, scraping. And as I mentioned before, sometimes women who have had violence perpetrated against them, the perpetrator wants to cut into them to show what he has done. We've also seen that with tattoos on the woman who has been raped. But there are a lot of risks, obviously, with this procedure, as you all can imagine. If it's done as an adult, or as a child, but we don't hear from the infant or child, it's very painful. There can be hemorrhage. The artery can be cut. There's swelling and infection. Many women have told us that for weeks after the procedure, if they were old enough to remember, they couldn't move, and they're held in a hut with women attending them as it heals. And it's very painful to urinate. People die, of course. Many women, infants and girls have died from this procedure. It's often done under non-hygienic situations, sometimes with blades that are not sterilized. And of course, the mental health and sequelae after this. It's interesting because some women who have had it done as infants don't really understand the normal female anatomy. So one of the things that we can offer as physicians and providers is to explain and normalize and help the woman understand what's happened. And I'll talk a little bit more about that. Long-term risks, of course, are very prevalent, and women who have talked about this, who have had it done, often describe the mental health sequelae, etc. There can be chronic pelvic pain, damage and scarring, chronic genital infections, Many women who have had this done have had UTIs that are untreated that lead to other problems. Painful urination and menstruation. Sexual health problems are probably the first thing that comes to mind and is often the case. And complications in childbirth if the woman has had an extreme version of FGC. Some of the most horrible things that can happen at the end, of course, are fistulas. And I'm sure that Dr. Mukwege and his colleagues have seen many of this. Injury to the genitalia, or if it's improperly done, there can be fistulas formed. So this is a long-standing complication that requires surgery. Perinatal risks, sexual health problems are probably that, and mental health sequelae are most of the ones that we've seen. Often women are reluctant to talk about this, particularly in our work with asylum seekers, but it's important for them as much as they can to tell us, and I'll talk a little bit about trauma-informed care in a minute, because this will be their case in immigration court. If we can prove this and say it's diagnostic, this woman will probably get asylum. There are two vignettes here. This is from a young girl who was 13. And her mother said that she was going to undergo this initiation. She didn't want to do it because her friend had died of it. But indeed, she did have it done. She didn't die, but she nearly did. So, even over the protestations of these young women, this is done often. And this is an example of someone working with Indigenous women, shining a light on this practice to show that it's a lack of knowledge, and there are ways that we can combat this and work with communities. I just wanted to tell you a few anecdotes briefly. When we do the work, two things came up recently, which were very interesting to us in our work. I was asked to see a woman to document that she had not had FGC. And so I turned to PHR for a question about this. I said, we've never been asked this before. Why is this correct? Should I do this? And PHR said, yes, absolutely, because you might be able, even if she has not had it done, there may be ramifications for her daughters or for somebody else in the family. So the good news is that we did see this woman recently. I don't know if Katie is on this call, but she was the student scribe. And the case was future persecution of her daughters, that if she had to go back to her country, her daughters would be cut. And she gained asylum. So she is safe and her daughters are safe. So this was interesting to us. So I suspect we might do more of this in the future. The other thing that was interesting in our work with this was a woman who said that she had had FGC, but she had been in detention, and a nurse had seen her in detention and said that she did not have it. This was at a detention center in Texas. The nurse said she had not had it done because she didn't see evidence of being sewn together. And when we saw her, we felt that she had it. We actually got a second opinion because we didn't want the other court to the government attorney to question. And the good news on that is that she also was granted relief because she had indeed had it. So there are all kinds of different things that occur with this particular form of sexual violence. So a little bit now about the gynecological affidavit that we do. The affidavits are scribed by our student scribes, and there are templates for the gynecological, the physical, and the psych. The interview portion is the same. So with every client, we do a history, the sequence of events that led up to the torture, the persecution, the cutting. We need to know who did it and how many people. Often the client can't remember, both because of trauma and because it's hard for them to speak of it. But we always do a trauma-informed approach. We ask permission before obviously the client knows why they are seeing us, but sometimes they can't speak of it. So if we have to stop that evaluation and reschedule, we will do that. We tell them what we're doing. We get their consent and permission. With the gynecological, it's important to establish rapport as best you can. And so the students bring, sometimes we have flowers or water or fruit to sort of normalize the environment as best we can. I do a pelvic, not an internal pelvic exam, but external. We explain this to the client. I tell her everything we're doing. It's a little difficult when we have an interpreter, but we always use a female interpreter. If sometimes we've only had a man, but then sometimes we've had to reschedule that. We don't really do a speculum exam at all. And then when I'm describing what I saw, and in concert with the interview that the lady has given us, I focus on consistency. Now, this is one of the things that I can say diagnostic. So the consistency levels are, is this consistent with what she told you? What you see consistent? Is it highly consistent? Is it typical of? Is it not consistent? In the case of FGC and initiation, it is diagnostic if I see it. So that's a really telling term to use for the court. I am diagnosing something that I have seen, that it matches what this person has told me. And as I say, it usually does mean that they will get protection. Here's an example of the affidavit. Most of the affidavits start out the same. There's the clinician's name and credentials. It is all the same, along with the physical and the psychiatric. Now, it is true that a woman who's had FGC could also have other physical, physical stars or something like that. So we might do a combined physical gynecological exam. This is the template that I showed you before. This is the format that we use, and the figure is put into the affidavit, and then the interpretation of findings is what the student sort of starts, and then the clinician finishes. And we do use, as I told you, the WHO definition. And then we get to the conclusions, and I go through, or the student goes through, sort of matching what the person has said with what we've seen. And then this last part, we have to say certain things, how many interviews we've conducted overall, the consistency of what we see. I could say typical of or diagnostic of if I saw this. My clinical opinion is said there. And then this statement, I declare under penalty of perjury that this was done and executed. This is all essential for court. So some of the findings through our HRI clinic, our asylum seekers have originated through all of these countries that you see, mainly type 2 and type 3 that we've seen. We did see one person who had the infibulation, but it had been opened up. PTSD and major depressive disorder were reported for almost half of the client sample that we saw. And recurrent urinary tract infections and blood retention during menstruation were the major complications that we saw in this particular group. This is the next video I want to show you. It's fairly short. I think we're in good time. And this was done actually almost a decade ago through UNHCR at their 60th anniversary, I think. And I wanted to show this because it really shows you the resilience of people and women who have gone through violent events. And I think that it shows that side that we have to never forget, how resilient these people are.
My name is Mukwege. I'm originally from Rwanda, and I was born in Burundi as a refugee.
أنا اسمي سحار، عمري 19 سنة، من العراق، من بغداد، ساكنة بذيابية بدمشق.
Me llamo Eugenia Mena Moreno. Soy desplazada de Urabá.
أنا ترحس محارب قرماريا من البحر كابيان تونسيا جاتي له.
In this, the 60th year of the signing of the Refugee Convention, UNHCR undertook a project of dialogues. Teams travelled to 7 countries and met with over 1,000 women and 200 men to talk and listen. This is some of what they heard.
To grow up as a refugee in Burundi, it was not an easy thing, because in the fact that I had a card as a refugee, and I was treated as a refugee, and I was many times called names as a refugee.
The conversations were filled with recurring themes: the need for documentation, food and shelter.
كنا بشقة صغيرة مؤلفة من غرفتين ومنافعها، وما نقدر نطلع لأن هي أرخص شقة لقيناها بصراحة وكلش تعبانة. هاي بعد الترميمات اللي إحنا سويناها هم بعدها تعبانة.
And the need for education.
هاري دلي تمرتي تماهيرة بناتي حنقول بناتي كسرح يدلي تماهيرة بتمرتي كسرح يدلي كاو نسب كم زناتي أنا شجرت لزرعه كما يستجيب وارث بيلو بزعق كمي هذا.
The dialogues gave the women a voice, and when it was too hard to talk, they drew pictures that spoke of their worst fears. Harassment, violence, abuse.
Mi nombre es Doris Berrío, soy desplazada, soy de Colombia. Me llegaron las primeras amenazas. Me llegó una amenaza por escrito, por un grupo armado, donde me decía que tenía que abandonar el barrio. Pero yo no presté atención a esa amenaza, sino que seguí trabajando por las mujeres.
أو تيومنا أو أنا أو تعمل طباع يكونه حتى ناتنا ما تيس نقول كبرت هاي نبرن كم دليتهم يمزحتهم سبي لنا مالتي.
Other women talked about not having a right to citizenship, how they were stateless.
كمان شعور ما انه حلو انه تلاقي كل الانظار عليك وكانه عاملينك شي مجرمه. انا ماني مجرمه، انا كل مشكلتي انه انا ما معي هويه لبنانيه وامي تجوزت انسان منه لبناني. هاي كانت مشكلتي، اكثر من هيك ما في شيء.
But the most pervasive issue was sexual violence. One woman after another told the story of how she or someone she knew had been raped.
That's 3 men coming and holding my daughter.
Seeing the women who have been raped many times, not even one, many times in front of their children, in front of their families, it's not easy, it's not something you can tolerate. But for me, I know that they suffer and I suffer with them.
Bueno, la experiencia más difícil y más cruel fue la violación, que eso era algo que yo no lo esperaba. Entonces esto es algo, pues, algo indigno. Algo que ninguna mujer pues quiere que le pase. Entonces pues es la experiencia más terrible que he tenido.
The men met apart from the women. They talked of the humiliation they felt when the women and their families were attacked. The conversations revealed a shared pain, but also strength. The women pushed back and said no to fear and yes to rebuilding their lives.
عندي معهد نحت تابع للUN، مؤسسة الUN بالسيدة زينب بعد المقبرة. من أشتغل بالنحت أحس براحة، يعني أرتاح من أشتغل بالنحت، أطلع اللي أنا أريده.
I never say that I cannot do. If there's something you give me, Juliet, please, this is the work, do it. I never say no. I try first and to see if I can do it. If really I see that I cannot do it, then I tell you no, I cannot do it. But I always think that I can do it.
Que tienen esperanza, que tienen metas. Y si tienen hijos, pues que luchen, porque eso es lo más importante para uno, sus hijos. ¿Ya? Que luchen hasta el final, que al final van a tener la recompensa. Y la recompensa es que los sueños de uno son sus hijos, y que sus hijos sigan adelante y que sean guerreras.
I think that's such a really beautiful video that shows the resilience and how important it is for us to bear witness to what happens to people who suffer this violence. So how to move forward? Well, one of the ways we're doing it through through our HRI and working with PHR is to provide this objective documentation so that these women can find safety and support and with their families. As we said before, that it does increase the likelihood that they will be granted asylum or a form of relief. So this is one way we can help. Combat misinformation, understand the forces underlying sexual and gender-based violence, avoid stigmatizing affected communities and sharing accurate information, and being advocates. I mean, I think that's one of the things that more and more we know in medical student education, and we as providers, we are advocates for the people we see, our patients, other people in the community, and it's up to us because we have the passion, the training that can really help and working with communities. We need to continue to learn and to listen so that we hear from our clients and from our patients so that we can do better and to make this world a better place. We need to have evidence-based work, so like PHR does, so that we speak from a position of knowledge and learn from the people that we see. I think that's the most important thing that we can do. And I think that's one of the things that so impresses me about all of you students, because you are advocates and you are going to make the difference going forward in our world. That is it for the presentation. The next slide is the references. And of course, we're happy to send that out, I think, Victoria. If there are any questions, I'm happy to take some now or later if people aren't able to marshal their thoughts just yet.
Just want to thank you so much, Dr. Griswold, for talking to all of us, educating us on this extremely important topic. So just grateful. Thank you.
You're most welcome.
I was curious if you could share a little bit about kind of your own process around your own mental health, kind of bearing witness to the survivors that you care for, and any advice you have as kind of we're all developing our own toolkit for self-care while we engage in this work in a healthy way.
Right. Thanks for that question, Lauren. Yeah, it is hard. I think one of the things that I find from this work is I love working with students and I love to teach. So that for me is sort of the added benefit of doing the work. I want to help clients. I want to be objective. I want to be the best, forensic examiner I can. But I also love hearing from students and listening to them and working with them. And I think that balances my mental health when I do the work. The other thing that balances me are, just regular life. And that's a balance that all of you will have to continue to learn about through your whole careers. Medicine is consuming, and listening to problems that people have and things that happen to people is very difficult. And we have the privilege of hearing things that other people don't hear, whether it's in your daily work as a physician or something like this that we do. So that's a lifelong lesson to try to learn how to balance, family, friends, animals. Many of you know I have dogs and horses. That's a huge relief to me. It's really helpful for your mental health. But you find what works for you. Eating healthy, exercising and trying to keep yourself healthy. But I think helping others also does give you some kind of mental health relief. I think one study has shown that people who volunteer and help, not in this way, but in other ways, endorphins, are running around because you're helping others. So I think that's some of the things that I find helpful.
That made me think about a question of like how you practice. You can't do this as a resident, right? You have to be attending.
You can do it as a resident. We've sort of looked at that. The problem with that is that if they have to testify in court, sometimes the opposing attorney might, attack that. But there are many residents who have had a lot of experience, like before they went to medical school or during medical school. So in that case, yes, I think you have to have a license. You have to be licensed to do it. So, and residents can, are often licensed. So it's not out of the question. We haven't really found a way to do that well here. But we have trained many of the residents, family med and psych, I think we've trained. So I know other clinics do use residents.
Okay, that's great to know. And then like practically, you just is it similar when you work for PHR, when we all go off in different directions, that you can sign up for forensic evaluations in your local area and you can just volunteer? And okay.
Absolutely. And many of our students who have gone on to other institutions for their residency go right into their human rights initiative clinics there. Yep.
Something to take note of when you're looking at where you want to go for residency, I guess.
Yeah, right.
If no one else has a question, I have a little bit more of a pointed question, just because I think the response would be interesting for everyone to hear. Dr. Griswold, what have you heard from some of our attorneys about the weight of the affidavits, specifically the gynecologic affidavits for the FGC cases?
They 100% say that it has been helpful, particularly in this case, because it's such a clear, consistent pattern. You know, I've used diagnostic of a couple of times with other things, physical things that I've seen, but when you see the evidence of female genital cutting, it is completely diagnostic, and there's no defense. You know, the government attorney, the ICE attorney, can't really say it wasn't, because you were the one that are testifying. And, you know, it's interesting, this is a pretty clear case, but other cases, for instance, like rape, when a sexual violence has occurred and a woman has told us about that, there's often nothing seen, right? Nothing tangible that you can see or describe. And then as the examiner, if you testify in court, it's your role to educate the court as to why that is. Just because nothing is seen, it doesn't mean it didn't happen. And then you have to educate the court about the trauma and memory and trauma. And you can cite articles. Sometimes we've done that in affidavits, but really as the clinician testifying, it's your role to educate the court, and they will listen. I mean, you are the medical expert, you know, when you're in the court. So that, I think, is a real service as well. There was one person I saw who told me that she had been raped and that she'd been taken to a hospital. She'd been bleeding. I forget what country she was from. And I believed her, and I wrote in the affidavit, and then was testifying during that case. And the judge at one point turned to me and he said, well, what would you say if I had documentation from the hospital where she went? That's how he said it. And I thought, oh my goodness, you know what, I believed her, or maybe he has documentation that nothing, who knows? But in fact, what the documentation was saying that there was evidence in that document from the hospital that she had been raped, and there was more evidence in that document. So, it's your job to just do the exam objectively as you can, listen to what you were told, and then make a determination about the consistency. And that's all you can do, is tell the truth as you know it. But attorneys do want these these forensics done.
Alyssa, go for it.
Hi, first off, just thank you so much. That was an informative talk as always. Second, I have a question regarding just FGM reconstructive surgery. So I was talking with Efreen about our upcoming event that we wanted to do. I just was wondering if you've heard from the clients, if they're interested in those types of surgeries, or if they're ever aware of those things.
Yes. Oh, thank you, Alyssa, for that. I was going to bring that up. Yes, I have discussed this with clients, and there is reconstructive surgery that's done. Dr. Marcy Bowers is one of the primary people that do the surgery. Amazing physician in California. And there's actually Penn University of Pennsylvania, I think, has a surgeon that does this. So it's an interesting topic with the woman themselves, because mostly they haven't heard of, well, number one, they may not sort of understand what's happened. So part of your role is to educate about that, normalize it. We've used pictures of normal genitalia with women I've seen in the past. And if they want reconstructive surgery, it can be done. Now, while they're seeking asylum, probably not. I mean, they would have to get the asylum, but insurance would probably cover it because it's part of it's part of correcting what was done and helping that person achieve their full, their full measure of what they are due. So yes, but I think it would have to be brought up probably through the primary care. I mean, you might mention it. I have mentioned it to some of the women that I've seen, but then we can do referrals. So any clinicians who's doing this work would make a referral on to primary care, OBGYN for further discussion. And that would be something down the line that if you were seeing somebody, if you were doing this kind of care, that you could carry that on.
Great. Yeah, I didn't know that one, Dr. Bauer's name, but Dr. Persek is the one that
Yes,
I read the paper.
Dr. Persek is at
from
Penn, right?
Penn,
Yeah.
yeah. So that was one of the individuals we talked about having as a speaker. So yeah, great connection.
Yeah, absolutely. Yep.
Any other questions?
I was just going to ask Dr. Griswold, first of all, thank you so much for speaking about this topic. The presentation was really informative, and obviously this is so important. So thank you so much for taking the time.
You're welcome.
And I was just wondering, just in general, even outside of the context of asylum evaluations, how you broach this subject with like patients who you might be concerned are survivors of SGB or gender-based violence, and how you make them feel comfortable, how you kind of like are sensitive to different cultures and things like that. So just general tips for how to start that conversation.
Yeah, thanks for that question. Well, I was lucky because my whole practicing life was on the west side of Buffalo, taking care of refugees. I was involved with 2 practices. We were all involved in the care. We were just down the street from Jericho Road. We all sort of started together. Dr. Glick started at Barton Road, and we had our practice on Grant Street. So that was where most of the refugees were resettled there. So I had the advantage of learning from refugee resettlement agencies, workers that I worked with, medical students. We started a refugee health clinic night at that time. So we were sort of involved in learning and listening as we went. And I think what that did for the women that we saw was it made it a comfortable environment for them, because that's who we saw. We had interpreters. We sort of tried the best we could to make it a comfortable environment for taking care of all of our patients. So I think I just sort of learned from mentors and from others that I worked with. And in primary care and family medicine, you sort of learn how to get rapport going. I love seeing people. I love listening and hearing from them. So partly that was part of it. And then also, asking permission and letting them tell me what they were comfortable telling me. And sometimes it takes a long time for a patient to tell you something that's happened. Now, obviously, if I was doing a GYN exam, I would go through this is what we're going to do, and I would explain and et cetera. And then, if I saw something, even if she herself didn't reveal, then we would have another conversation about it. So I think I was just very fortunate to be in a situation where it was sort of a constant learning environment.
Thank you for that question, Snea. Any other questions, comments, concerns about the series at all? No? All right, then we'll end there for tonight. If anyone has any questions, you can always put them into the form, which we're going to put on the website now, to just say that you can watch the lecture, and we can answer any of those in 2 weeks from now at our session 2, and Dr. Griswold can respond to those, and those responses can come directly from her if anything comes up. So thank you everyone for being here tonight. Thank you, Dr. Griswold, for giving us this talk.
My pleasure.
And have a lovely Wednesday. Bye-bye.
Okay. Bye, everybody. Thank you.
Thank you so much.